Good morning to everybody. So the topic is how to treat these patients with dialysis. Okay, it's here. So this is the rationale. Okay, thank you. This is the rationale and controversies that I found in this topic. So iodine is normally freely filtered by kidneys, but largely reabsorbed by kidney tubules. Renal clearance of iodine is responsible for the at least 2/3 of total plasma activity elimination. So the importance of the kidney function is very high to treat these patients. But the topics, the therapeutic guidelines and dosimetry are described in patients with normal renal function exclusively. So there are very limited knowledge about how to treat these patients at the end stage of renal disease. The literature are very few. There is some uncertainty about the introducing by prolonged exposure of higher radioiodine blood levels during the time interval between the administration of the treatment and the first post-therapy dialysis. And there is no agreement at all on the radioiodine treatment and the activities that should be given to these patients. However, the remanent ablation in these patients is crucial because if they are considered to go for a kidney transplant, they should be free of cancer. And on the other hand, there is another controversy, is these patients has a higher prevalence of thyroid carcinoma in general, and the therapeutic, so in conclusion, the therapeutic procedure requires controlled dosages and individualized administration guidelines in order to minimize radiation exposure to the patient family and personnel. So, which is the viability of radioiodine in the blood of these patients? The radioiodine clearance rate in these patients depends on the type, duration, and frequency of the dialysis, of course, but also in the interval between these procedures. And as I told you before, there is an increase in total body radiation dosimetry. The half-life of radioiodine in this patient is 4.5 times superior to that of patients with normal renal function. Here you can see an example of a patient with renal failure, and this is the normal patients. So there is an increase in radiation that falls after the first hemodialysis and falls again after the second one to the normal values. So the contents of this lecture, I will try to answer these three questions. Should the radioiodine indications and dose be modified in these patients? What is the optimal timing for dialysis after the administration of the treatment in order to maximize the treatment benefit while minimizing the risk of the patient and the treatment and the treating medical personnel? And finally, what special precautions should be observed? And the best way to answer this is a case. Let me show you this case we treated at my institution. It's a young male, 22 years old, with chronic renal disease and hemodialysis and since March 2008. He was transplanted previously in 1987 and again in 1999 with a chronic rejection. He's suffering hypertension with cardiac repercussion, hyperuricemia, and hypercholesterolemia. He was surgically treated in June 2008 with a total thyroidectomy plus a right modified radical neck dissection, levels 2A and 3. And the pathologists say that it was a papillar carcinoma, the size was 1.5 centimeters, so it's a T1. And the lymph nodes were positive for papillary cancer, so it's an N1B. So the question is, should we treat these patients? Yes or not? Raise your hands. Because I'm going to ask you after the talk, and then let's see what happened. Who should treat this patient in this room? 1, 2, 3, 4? Okay, there are some people that not. Okay. So other questions could be hemodialysis before and after, or just before, or just after. So there are many questions that in this patient. So this is the procedure. This is the room that we have at my institution. So it's a crowded room with patients in these beds or with a lot of personnel attending the patient, but also the machines to perform the hemodialysis. So it's absolutely impossible to introduce a patient with a treatment that has been treated with radioiodine. So we have to brought all these personnel and these machines to the patient instead. That means that we need a multidisciplinary team. From the part of nephrology, we need a clinician, a nurse, an assistant, and probably a technician because we have to connect this machine in the room. We have isolating the patient. From the nuclear medicine, we, as you know, well, the physician, the nurse, the assistant, and of course the cleaning staff, because it's also important. And from the radiation protection, the physicist and assistant technician in order to measure the patients and maybe any other things for dosimetry. So which are the risks in this population, on this treatment, in this multidisciplinary team? So the patient, of course, because there is an increase, as I will tell you many times during this lecture, but also the nurse, the dialysis nurse, the dialysis assistant and technician, because they are managing the patient, managing the equipment, and of course, the nursing nurse and clinical staff. So we should give different training for this personnel, and also all the radiation protection devices will be available to this personnel in order to minimize the radiation risks. Here you can see the room that we have to isolate the patients. This has been taken from the bed of the patient. So this is the toilet. This is the door of the room. So here you can see pure water pipe for dialysis. This is a special water for the treatment. And also here you can see an video camera, in order to look at the machine. So this is another picture. Here is the pipes, providing suitable water of chemical and microbiological quality. Second, here you have the machine. We have taken the machine from this other room. And of course, we need to check this scroll, but outside this room. So the dialysis personnel should be outside the room, close to this, and using this camera, we can do that. Additionally, we have to connect all the drainage, all the dialysis drain pipes must be connected to the liquid radioactive waste tank. And you have to take into account that 4 hours of dialysis, which is the regular time of dialysis, means 120 liters, which is a lot. So you have to be prepared, and you have to have absolutely empty the tank before to do the dialysis. Here you can see how we connect to the toilet this all drainage. And here finally we have another camera just to look at the patient if he's doing well at the bed, whatever. So what is the optimal timing for dialysis? So the pre-treatment dialysis is important because inorganic, as I told you before, inorganic iodine is cleared by dialysis. The serum inorganic iodine level should be as low as possible. So in general, there is an agreement that, or consensus in the literature, that this should be performed immediately before the treatment, so that patient's plasma pool of stable iodine will be as low as possible. So we have performed already the dialysis in this patient. This is not radioactive, so we can connect the machine to other drainage. So we are giving the pill, of course, orally, and then we are doing some measures after giving the pill, but every time before and after the dialysis. So after we have given the treatment, we have to take into account which is the time to perform the first dialysis. And this depends on the exposition, the radiation dose exposition, and the amount of the treatment. And there are different possibilities. There are some groups that they perform 2 days after the administration of the treatment, and there are others that perform every day, 24 hours after the treatment. So the first, after 24 hours, the second, the third, the five dialysis. And here you can see the examples of these 2 papers. In this paper, they treated, I think, 5 patients only, so the data are very, very low. But here you can see the decrease of radioactivity before the dialysis and a big fall after the first dialysis, and here you can see after the second one. In this other paper, they presented 3 patients, and here you can see the amount of radioactivity that decreased in each of the 5 dialysis they are performing every day. So they stay the treatment 1 day, and at the 24 hours started with the first 2, 3, 4, and 5 dialysis. And here you can see the differences. So, but now we have to calculate the activity of radioiodine. So, and there are different approaches for that. Could be a conservative approach using a lower activity in general than a standard. There is another much more aggressive, which is increase the activity, priming the therapeutic benefit, because the dialysis itself causes an accelerated activity clearance due to elimination of this radioiodine in 50–70%, as you can see in the examples I showed you before. And finally, there is another more rational, that is dosimetric study. So they are giving a similar activity than the normal function, renal function patients, but ensuring safety by calculating the maximum tolerable dose of radioiodine based on the experimentally derived individual patients' iodine kinetics. And here you can see a review of the literature. These are all the patients has been published. This is the whole information that you can get in the literature, at least at this time. And look at the diversity. So this group said that there is a 20% of empiric dose, dialysis 48 hours after, and this is the way. So there is other papers that they say, no, there is no restriction to the doses. Others are increasing the doses, significantly larger doses. Others say just 1/4 of the empiric dose, and then dialysis every day. Some of them are using dosimetry. They say in this paper to increase to 125% above the normal empiric dose, and well, this is the diversity in only 22 patients in the literature. So we have to think about that, and I have summarized all this information in 2 points. So there are 2 possibilities. One is modified empiric dosing, and the other is dosimetry. By modifying these empiric dosings, we attributed to times, these doses are attributed to times and procedures to therapy dialysis sessions. For example, if you perform the dialysis at the 24 hours after the treatment, this is equivalent to administer the half of the amount of radioactive iodine having the dialysis 2 days later. So you have to calculate this in this way. And this is the suggestion of other authors. For example, this is a 40% of decrease of 25 or 22. But all these modified empiric dosing does not take into account very important aspect, like is the patient's variables. For example, the amount of thyroid remnant which is present, the presence of metastasis, the presence of poorly functioning access, residual renal function, and others. So we have a lot of limitations for this. So the best way, from my point of view, is to use dosimetry in these patients and use the same that empiric, but take into account the dosimetry. So there are some pros and cons to administrate this treatment in these patients. The adverse effects are higher because the time of availability of radioiodine is higher, and the amount is also higher before the dialysis. So the salivary gland and bone marrow toxicity could be higher, and increased the risk of toxicity by severely impaired activity clearance. And there is an association because these patients also have anemia, and that could increase with this toxicity. And there is also an increase, a possible increase of secondary malignancies. But on the other hand, these patients are absolutely dependent of this treatment, because the impact of radioiodine treatment, there is a clear impact on the survival. If renal transplantation is not performed, mortality is clearly influenced by renal disease. If renal transplantation is planned, cancer-free is a necessary prerequisite, and obviously radioiodine has sufficiently demonstrated benefits in terms of survival, quality of life, and expenses in these patients. So, general recommendation for these patients could be summarized in this paper. And they said that for preparation of the patient, a low iodine diet is recommended. A discontinued povidone, of course, and plan for those soon as dialysis, the first dialysis. To dosify, to measure the activity of radioiodine, there are two possibilities, as I mentioned. The first one is dosimetry, and if not available, try to minimize with using this percentage of empiric dose and dialysis on the day 2, or as you can see. And this is some recommendation for the personnel. But go back to our previous case. So now, is everybody agree using this treatment for this patient, or is somebody else that reject this treatment? Well, it's nobody's answered. Okay, so we went to the treatment for this patient. So the next question is thyroid hormone withdrawal versus recombinant TSH. Which one? Who will go for thyroid hormone withdrawal or TSH? Raise your hands. Any question about this? No question. Everybody is absolutely sleepy. Okay, we went for a thyroid hormone withdrawal for 4 weeks in this patient. This is the data. This thyroglobulin was 24, but look at this anti-thyroglobulin antibodies was very, very high, so this is not a real value. And the TSH increased very high in 4 weeks, 579. The blood counts were normal, the electrolytes were normal. This is very important. This is part of the nephrologists want to check the weight, the height. They schedule the different parameters of the dialysis according to this. So, should we go for a dialysis before? Anybody thinks against or not? Okay. Yes, 3 hours, 300 millimeters per minute. So, which dose do you give, or would you give to this patient? Any comments? Sabas? Standard dose. Any other comment? No? No comment. Standard dose. This is not prepared. Very good, very good. Well, this is our thought, because there is nothing in the literature, there is no clear agreement. So dialysis after and when? Well, we perform a first dialysis 24 hours after the treatment, and 48 and 72 for different times. So 4 hours the first one, and 3 hours and a half, depending on the dose exposition of the patient. And here you can see the whole body scan. Look at the salivary glands. There is a high activity there. So you have to take into account that these patients are treated by dialysis, but there is a clear restriction of beverages or drinks, and also the fluidotherapy. So there is a big problem with that. So probably the toxicity increase in these patients, and also the constipation is the rule in these patients. So we saw a clear activity in the neck, consistent from a point of view in rest of the remnant thyroid, but possibly another other lymph nodes. But the patient was followed by the clinicians, and in 6 months later, they performed an MRI, and the MRI showed right lymph nodes, levels 4 and 5, And consequently, the patient was surgically treated by a radical neck dissection. The other two levels that the previous surgery was not taken out. So, and the pathologists say that these were metastases. Should we give another treatment to this patient or not? Well, we went for 2 more treatments as a normal patient, using a mild reduction of the dose, 120 in March 2009, and another one because we saw a rest here after the surgery, and here we didn't see any clear uptake. So this is the results of the thyroglobulin and also the antibodies that were decreasing more or less in the data of TSH. So this patient finally was transplanted and is doing well, and so we are happy to comment this after so many years. So in general, the conclusion of this talk will be as follows. Treat these differentiated thyroid cancer patients with this disease when indicated. So there is no clear rule to avoid the treatment in these patients. And empirical activity for localized disease of locoregional progression, 30 or 70 millicuries respectively, or just reduced to the half the normal dose of the normal individuals, appears as safe, but when possible, please do dosimetry. We should administer as soon as possible after dialysis, 24 or 48 hours after, schedule the next one. Only the first post-therapy dialysis sessions need to take place in the hospital, because once the radiation exposition rate is lower than normal, you can send all this liquid material to the normal drainage pipe. And at these tissues, as I mentioned, dosimetry should be the best option. And this is all about that. Thank you.